right, we're going to make this fun, hopefully, and let me see if this works. Is there an on button to this, Sean, or is it just you just start pressing stuff?
Yeah, there's an on button.
On the side.
Yeah, we're recording.
Okay. All right.
It's got her mic'd up, so most of us are not going to be.
Okay, good to go? All right, hi everybody. My name is Rachel. I'm the nursing practice specialist for neurocritical care. I also have the NSU as well, and a couple other departments. But before we get started, I've been here at Bayview for about a year. Before I came here, I was at shock trauma, and then I was at JHH in neurocritical care. So I have some exposure and experience with EVDs, both here at Bayview and elsewhere. And basically the whole ask was to come and give you guys like a brief overview of the drain, some background, some physiology, and then just some hands-on with the device. Sean and I both realize that this is something that should never, ever stay in the emergency department for very long. You know, it's not fair to you and your acuity and your patient assignments, and these patients really should just be expedited upstairs or elsewhere. But in the interim, you know, as much as we want these patients to leave immediately, they don't always. So we want to be able to equip you with some knowledge to be able to handle this device safely in the interim. So really for today, we're not going to make you guys experts on this device. You don't need to be. What I really want to just relay is how to manage this safely and effectively until they can leave you. So we have, like Sean said, we've got capacity calls going on, and we're really trying to prioritize getting these patients out as soon as possible. So we're going to go through basic pathophysiology, indications, the patient populations that you guys will see here at Bayview for the device. We'll go through the insertion process, soup to nuts, the whole thing. Review how to level it and transduce the ICP onto the monitor. Unfortunately, I don't have a monitor that has the capability to do like a demo mode for that, but we'll just kind of talk through it. I'll show you what the epic orders should look like and what you guys should be paying attention to with those orders. We'll go through a couple troubleshooting scenarios, and then we'll just play with it, and so you can get some hands-on time with it. Right, so we're going to start with just an overview of intracranial hypertension, so the predominant reason why we're placing this drain in the first place. So we all know that the skull is a fixed compartment, and unlike the other compartments in our body, we really don't have a large breadth of ability for it to expand and for us to really allow for any increase in tissue, blood, or CSF without those compensatory mechanisms failing. So, you know, a trauma comes in and we can bleed into our belly before it becomes, you know, a really big problem, or we can bleed into our chest and we have a lot of space there, or our pelvis. But we know the skull is not the case. So we know that the intracranial volume is composed of three different things: 80% tissue, 10% blood, and 10% CSF. It always has to equal 100%, and if there's any change or increase in any one of those three components, then the others are going to have to compensate and drop. So we have the ability to compensate for a limited period of time. The brain can do that by shunting CSF other places. It can absorb CSF at a faster rate, or it can shunt venous blood and also cause arterial vasoconstriction and vasodilation. But at a certain point, if any one of those three components increase beyond what it should be, those compensatory mechanisms will ultimately fail. And we see that when patients come in and, you know, they get a CAT scan, and we see on the CAT scan that they might have some herniation physiology. And most of the time, you know, you guys will see typical herniation going through the foramen magnum here, that big hole in the middle. And that's what you kind of normally see when, you know, compression is happening down the brainstem. But herniation can occur in other places as well. We've got subfalcine, transtentorial, central herniation. We can herniate across, we can herniate up, we can herniate over structures. So it really just depends, but that will ultimately be the result when our compensatory mechanisms fail, and that is considered a neurologic emergency. And that is, you know, before we get to that point, we want to be able to intervene surgically, and that's, you know, kind of the whole point of the EVD. So going back to nursing school, we've got our Monroe-Kelly hypothesis, which is basically just the fancy hypothesis for what I just told you. Intracranial volume is composed of tissue, CSF, and blood. And you can see on the axis here, we've got pressure and volume. And eventually, as volume continues to increase, our brain will compensate. But then when it gets to a certain point, intracranial pressure will rise when those compensatory mechanisms fail, when the volume eventually becomes too high. So what do we define intracranial hypertension as? So a normal ICP we know is less than or equal to 15. Intracranial hypertension generally is categorized in the greater or equal to 20 range. And then any type of intracranial emergency we generally see as greater than 25. Obviously, this is going to depend patient to patient, but that's usually at the point where we're giving, aggressive hypertonics, surgical intervention, things like that. So we know that any changes in those three components are going to cause an elevation in ICP. And we can see that in three different ways. Through mass effect, so you'll see kind of that terminology on your CT scans, and that really is categorized by hematomas, tumors, abscesses, infection, or swelling from ischemic infarcts, which generally happens in the 24 to 48 hour range after an ischemic injury. And then we have our CSF category, increased production, obviously hydrocephalus, choroid plexus tumor. So we know that our CSF is made within the choroid plexus structure of the brain, and if there's a tumor there, that's obviously going to impact CSF production. And then obstructive hydrocephalus. In a healthy, normal brain, our ventricles should communicate with each other, and that flow should be kind of continuous and unobstructed, but there is pathology where, we have obstructions and the ventricles do not communicate normally. And then excess blood volume. So our venous sinus thrombosis, which you may or may not have seen come through, it's kind of more on the rare side, seen a lot more in younger women, usually with a coagulopathy component, but that's one patient population. Elevated CVP or patients in heart failure who are fluid overloaded, and increased cerebral blood flow. So what are we really worried about at the end of the day? Brain injury, right? Cerebral ischemia, decreased perfusion, and cell death. And the way that we can really monitor that is through the CPP. Are you guys familiar with cerebral perfusion pressure? Okay, so this is a number that you might have seen on the monitor, you might see in the flow sheet. And this really should be something that you pay attention to in these patients. So that's going to be our mean arterial pressure minus our intracranial pressure will give you the cerebral perfusion pressure. So we really want that textbook to be above 60. What we find in patients with low CPP, so they have maybe a normal map, but their ICP is very, very high, we will eventually see hypoxia and ischemia. On the converse side, if we have a high CPP, that can cause hyperperfusion and actually make edema worse. So these are going to be our super hypertensive patients, and then also patients who have autoregulatory dysfunction as well. So when you're putting these EVDs in and you have ICP monitoring, it's really important that you're paying attention to what your CPP is as well as the ICP. And generally, there will be a goal for you in the orders, so that's just something to be mindful of. There are different things that we as nurses can do actually to really kind of facilitate an environment for a good CPP, and that would be keeping the head of the bed greater than 30, right? These patients should never be flat. That's going to make your ICP high. Keeping the neck midline. There's nothing that makes my heart hurt more when I come in and the patient's like this. Makes me very sad. So try to keep their neck midline. Towels, pillows, things can help with that. Different C-collar, also great. Osmotic agents, so our 3%, our bullets, our mannitol, kind of used in that acute phase when we have an increase in ICP. Sedation, obviously, we can take the patient completely out of the equation and put them down. Therapeutic hypothermia actually decreases metabolic demand, so that also will decrease your ICP. And then, obviously, we've got our surgical intervention, which is what we're talking about today, our EVD, and we can pop their top off and do a craniectomy and let them swell.
Can I just say one thing
real
quick? So basically, all this, what you're trying to do, we talk about primary injury and secondary injury. We can't do anything about the primary injury. The patient had a stroke and tissue died. Nothing you can do about that. Everything we're doing here is really to prevent any more injury from occurring and any more of that sort of fragile brain tissue that's maybe a little bit hypoxic, not getting perfusion. We're trying to preserve that. So all these things is with that goal in mind, preventing any further injury. So I think it's just an important distinction to make at times.
Good point. Thank you. Okay, so these are going to be your indications for putting a monitor in. So generally, GCS of less than 8 is going to be your trigger. Obviously, this is all patient dependent, but that will really indicate severe head injury. Your exam, your motor exam, it's all going to be very poor. So we kind of say less than 8 intubate. We know that their airway is generally compromised at that point. Again, it's just kind of a general rule of thumb. Any abnormal neurological findings, so your patient has posturing, extension and flexion, kind of those low-level motor responses, that could be another reason why you would want to go ahead and put a monitor in, as well as pupillary change. Pupillary change is going to be one of your number one indicators for herniation, and that's because for tonsillar herniation down the foramen magnum into the brainstem, it bypasses cranial nerve 3. So your ocular motor nerve will actually cause pupillary dilatation, and that's how you kind of know firsthand that things are going in the wrong direction. As well as cerebral edema and midline shift. So you can see up in that first picture, that's a really good representation of midline shift. We've got a giant bleed, a giant ventricle, and in the picture below that, we've got a pretty bad intraventricular hemorrhage. Those ventricles are really full of blood. And then obviously our trauma patients as well, which you guys see most of the time. So ventriculostomy, EVD, IVC, they're all the same thing. People at Hopkins here call it an IVC a lot, intraventricular catheter, but it's the same terminology for all different things, or for the same thing. So this is a very common neurosurgical procedure. We do it at the bedside down in the ED, but patients can also get it in the OR. And really what we're trying to do is mitigate that high ICP and drain. So it kind of is like a 2-for-1. So we can both monitor and drain. And we can use this in our patients with hydrocephalus, so they have excess CSF, traumatic brain injury patients who might have a bleed, or ICH and subarachnoid patients, either aneurysmal or hypertensive, as well as shunt failures. So patients come in, they might have a shunt for a long period of time, it's no longer working, or it might be infected. We can actually externalize that shunt and put an EVD in as a way to mitigate that until they're ready for the shunt to be fixed and internalized again. And then also infections and different neoplasms as well. So basic overview of what we're talking about today. We have excess CSF or blood within the lateral ventricles, so those are your bananas on your CT scan. And we want to divert fluid and monitor. So again, it's kind of a 2-for-1 situation. So we put a small catheter in the lateral ventricles, and then we connect that to the external device, the EVD. And this will drain excess fluid by means of gravity and intracranial pressure. So it kind of creates this pressure gradient, which I'll get into in a second, and that's how it actually works. And again, this system drains and monitors. There we go. So how does it work? So what we have here, there's 2 different levels of measurement on the device. So we have centimeters of water is one method that they can use, or millimeters of mercury. Here at Hopkins and at most places in the adult populations, we use millimeters of mercury, which is very convenient because our ICP is measured in millimeters of mercury. I've worked other places where they use centimeters of water, but it's all neurosurgery dependent. But here we use millimeters of mercury. So we call this particular level of measurement a pop-off, and this actually will create a pressure gradient. So your ICP has to be greater than the pop-off for it to drain, okay? Which is an important thing to remember. So if your ICP is 25 and your pop-off is 10, will you drain? Yep. So your ICP is 25. Your pop-off, so your measurement on this device, is 10. Your pop-off is this measurement here. So whatever the setting, I guess I should say the setting. So if the pop-off is 10, that's on centimeters of water. Let me go back up to millimeters of mercury. If your pop-off is 10 and your ICP is 25, will you drain? Right? Because the pressure in your head is greater than the setting on the device. Does that make sense?
Yeah, but the pop-off is not the goal ICP, though. They're different
No.
things.
The pop-off is this measurement on the device.
Is that number something like the physician would give you, or you just know? Or...
It's something that they order. So the neurosurgeon will determine, based off the findings on the CT scan, what their opening pressure was, what they should have the setting at. And then over time, when they come upstairs and, weeks and weeks later, if they still have it in, we'll eventually wean the patient down and we'll change that. But just remember that your ICP has to be greater than the setting.
I understand the first person. I guess, but is it a measurement of some sort?
It's just the terminology we use to talk about what number we're setting this at.
Yeah.
So will it, it'll automatically
I guess I'm trying to figure how they
ICP
figure out what
to
that
number?
is.
When
So-
it originally drains it,
Like
right?
from whatever excess fluid in their head, whether it's
Yeah.
blood
It
or
will eventually, all things being equal, it would equilibrate, right?
Yeah.
So if you set it at 10 and everything else is equal,
yeah.
which is never the case, right? But if you were just looking at pressures, it would eventually equilibrate and both would be 10. But there's a lot of other factors, there's brain tissue, there's swelling,
Yeah, 'cause
there's
it
things
won't
that are
suck
causing
brain
it to
tissue
go up.
out.
Mhm.
But
Right, right. So, but that is, you're just setting a gradient here, so that it's not always it won't necessarily always drain. So if your patient has a normal ICP, it's less than whatever, then it's just not going to drain.
Sure.
So a lot of it depends on the reason why you're putting this in and how much you want to drain. If it's a trauma patient and they've got severe cerebral edema, it's always going to be 0. They're just going to put it at 0 and let it drain all the time. If it's a subarachnoid patient or it's an intraventricular bleed and you don't want to over drain and get too much stuff out of there, then they might set it at 10 or 15. So it drains a little bit. It gives them some safety to get some of that off if their ICPs rise, but it's not going to constantly drain.
So
But
if your ICP is higher than the pop-off, then it's going to always drain.
It's going to be draining.
So if your ICP is 12, then it's going to drain?
Yeah.
Even though the 10, okay.
Yeah.
Not
And
as
it may
much, but yeah.
exactly.
Right,
Not as
okay.
much.
But there's pretty high variability about where that pop-off number will be ordered based on
What's
the
going on with the
mechanism.
patient. For example, if you have a subarachnoid that comes in and they have an aneurysm that's
Yeah.
bleeding, they're going to actually set that a little bit higher because you don't want so much pressure on the aneurysm wall. It will cause it to rebleed. So for those patients, we might set it a little bit higher as opposed to like a trauma, like Sean said, it might be a little bit lower because they just want all that blood to come off. Does that make sense?
Yeah.
Okay. I keep pointing at this. That's not yes. Okay. Great. We answered that. Okay. We all clear on that? Is that good?
Yeah.
Okay. All right.
But yeah, just keep in mind that your goal ICP is different. That's a good point that you're bringing up. Like, they're not the same thing. Your goal ICP is not the same as your pop-off.
Right, yeah.
Yeah.
Logically,
Yeah.
that's kind of like I draw a straight line from one to the next one. Like, I
Mhm.
want it to be this, I'm going to set it to that.
Yep.
Right,
And you
that's
will-
what it seems like it's doing. That's why I had such a hard time trying to understand how they're coming up with what the actual pop-off is, what that is.
Yeah, it's going to be completely dictated by the
And
surgeon.
the thing is whenever you're draining, you think of it as one system. Everything in the head has a pressure of whatever, but it's not exactly like that, right? We're draining a specific spot. So if you create negative pressure in that one spot, it's going to pull things into it. That's what she was talking about with the subarachnoid. So that's kind of where some of these things get into is they may have to look at where the bleed is, where the swelling is, because you actually could cause more problems if you then all of a sudden reduce the pressure significantly in one area and then it pulls all this stuff. And we see that a lot, like just to illustrate the point, lumbar drains can be actually very dangerous, right? Because if you all of a sudden create like a negative pressure in the spinal column.
Don't tell them what
Oh,
happens.
sorry.
That's later.
Something bad happens. Got
it. So it's not. So just to say, there's a lot of reasons why they would change the level of pop-off. Your overall goal ICP is usually the same on your 20.
Yeah.
And that'll be in your orders. So it'll be very obvious to you, and we'll show you that. So what we're talking about today is the external ventricular drain. So like I said, 2 for 1. You get to drain and monitor at the same time. It gets placed right directly in the lateral ventricle, those bananas on your CT. The other thing that we see a lot of the time, like Evan had said, down in the emergency department, is what we call an intraparenchymal monitoring device or a Codman bolt. And simply the difference between these two is that the Codman bolt will only monitor the pressure in the brain. It just sits in the tissue and it gives you a number. That's all it does. As opposed to this, that's a little bit more complex. It has, leveling and things like that you need to be mindful of. So this drains and monitors, and the Codman bolt will simply just sit there and monitor. The reason why you would have a Codman bolt over an EVD is if you don't necessarily need to drain something. For example, if you have a patient that comes in with an anoxic injury, they have a lot of edema and swelling, but they don't necessarily have anything, no CSF, no blood, nothing to divert. So you just simply want to know what the pressure is in the head, and then maybe at some point they would have to decompress with a craniectomy or something like that. But that would be really the difference.
What kind of bolt are you calling it?
It's called a Codman bolt.
Codman?
Codman, yeah. So
Okay.
you'll see like,
It's just the brand name.
Okay.
Yeah.
Yeah, I just didn't know if it.
it's like a box. It just looks like a
Okay.
box. It just sits there and gives you a number. That's all.
Okay.
I gotta keep pointing at that. Someone tell me to stop. Okay. All right, so insertion. So this is going to be the whole process start to finish. It's a completely sterile procedure. So they're going to drape the patient just like they would a central line. Everybody gets sterile. The neurosurgeon will identify the landmark. Generally what they use is what we call Kocher's point. They usually go on the right side of the brain because we want to avoid the language centers on the left. And they will drill into the skull through the dura. They'll place the ventricle, or they'll place the catheter directly into the ventricle, and then they will get a number, what we call the opening pressure. So that's what the pressure will be within the brain. Essentially, it kind of just looks like a little graduated, what's like the terminology for that?
Manometer.
A manometer. And it'll go up, and they'll be able to say, you know, opening pressure is 25 or greater than 25. And then that will be part of the way that they determine what the pop-off will be. And then they'll attach the catheter to the EVD and then secure it to the scalp with a suture. From the nursing perspective, what we will do is the resource nurse or the charge nurse from the NCCU will come down and actually prime and set up this device for you. That's not something we expect you guys to do. So what they'll do is sterilely, they will prime this whole thing with preservative-free saline and get it ready for connection to the catheter. You might have to assist them as a non-sterile assist, you know, to open packaging or flip off the caps or something like that. Generally, it's a two-person situation for setup. You'll also provide analgesia, manage the patient throughout the procedure. You can put these in awake patients, so this could be a moderate sedation situation potentially. You'll zero and level the device once it's attached, and then transduce and monitor your intracranial pressure, record your drainage output every hour. And just as a sidebar, the nurse is the one primarily responsible for this device. You should not be having respiratory or physical therapy or anybody else touching this. This is the nurses only, and that is just to maintain like a safety aspect to everything. We've had situations in the past where, you know, they're like, oh, just go ahead and clamp them when you're suctioning, and then the wrong stopcocks get turned and bad things happen. So it is your piece of equipment, just like the A-line or anything else. So associated risks, we can put it in the wrong place, obviously. So it doesn't happen all that often, but we do get a CAT scan to confirm placement immediately afterwards. It can occlude, so, you know, the catheter is very small. You can see this here. It's, you know, not a very large catheter at all. The diameter of the one that's actually in the brain is not much bigger than this. So infection, patients who have different fungal infections, it can clog. Brain matter, blood clots can all cause occlusion. Neurosurgery is able to flush the catheter. Nurses do not flush the system, and they do not flush the catheter. So neurosurgery can come and troubleshoot and flush if needed. Bleeding or hemorrhage, obviously, so patients who are on anticoagulation, if their coags are off or we know they're on anticoagulation, we can give them platelets or reversal prior to inserting this device. It's not a complete contraindication. And then obviously infection is going to be our biggest concern, so meningitis causing ventriculitis or brain abscesses, and then that can happen through CSF leaks. If the patient has a systemic infection already, if we breach the system, because once this gets attached, it's a closed system, so it should not be, you know, necessarily being opened for any reason, or if the dressing or the field is no longer sterile. We do give prophylactic antibiotics prior to insertion to help mitigate that.
So if they're putting one in, you know, then you need to tell them to give antibiotics.
Yes, and it'll be
When we
part
did
of the
it, they
order
were like,
set.
We want this and this, and they wanted it all in before we started.
Yes. And I'll show you what they normally give. So here's our little EVD anatomy. So we have two different kinds of devices here. We used to have three, but now we only have two. So we have the Codman and we have the Integra. So just going through the Codman, this is here, like I said, the two types of measurements for your pop-off. So like I said, we're only going to be dealing in millimeters of mercury, or we should be. This here is what's going to screw onto the pole. So this is how you attach to the pole. This here, this string, is really like a safety thing. So you put this on the pole, on the IV pole, you want to make sure this is nice and tight. So if this for some reason were to fall off, it's not going to completely drop to the floor. So this is just there to hang as like a backup safety situation. You can also hang it like on the back of the stretcher. As long as it's level, it doesn't really matter where you put it. This little black piece here will actually help you keep it level, so it can kind of go side to side like that if you need to keep it straight there. The way that you would manipulate the burette is this little white knob here. So that's where you would adjust your pop-off. The burette is the collection container. So this is where all of your CSF will be draining and what you will be emptying every hour and recording. This is obviously the catheter or the tubing that connects to the catheter. There are multiple stopcocks along the catheter, so there's going to be one closest to the head. Generally, we do not touch this. We just leave it open. What we're going to be manipulating is the stopcock on the device. So the reason we have this here is that you can actually clamp it off and allow CSF to collect and get samples from this port. Nurses here at Bayview do not collect CSF samples. Something to be mindful of because neurosurgery may ask you to do that. I don't know why they would ever ask you to do that downstairs, but at JHH, nurses do collect CSF samples, so they just need to know that that's not something we do here at Bayview. There's another clamp here as well, so something to make sure that is always open if you're troubleshooting because it can be kinked. So there's a clamp there. And then this is going to be, these two stopcocks are going to be the main things that you're going to use. So let me put the transducer on.
If they ask us to collect a sample, are we okay to turn it off and they can do the actual collection, or should they just?
I would just let them touch it. Yep. All right, so here's your transducer will be hooked up like this. So this stopcock is going to be the one you're going to be manipulating to clamp 0 level, and this is going to be your one that you're going to mostly manipulate, which we'll get to the different positions of it. But down is going to be your patient, okay? Up is your burette. And then to the side is your transducer, okay? So when we're keeping this open to drain, we leave it open with the stopcock off to the right. And the reason we do this is so that we can actually see, it's not a true waveform, but we can see a little bit of a waveform while we are open to drain. And the reason we do that is because when patients, upstairs or in the ED, if for some reason we would look at the monitor and the waveform went completely flat, we would know something is wrong, maybe got pulled out or dislodged or it's kinked or something like that. So it's kind of like a way that you can make sure that it's still accurately in the right place and that it's draining. Okay, so open to drain, we leave like this. To clamp, we can clamp up or we can clamp down. When we are leveling our system, we want to clamp up. Okay, and the reason we do that is because we want to be able to get our ICP. So we have it open to the transducer and open to the patient. So when we're getting our ICP, we're clamping up. If we clamped down, we're going to get the pressure in the canister, which doesn't really help us, right? We want the patient's ICP. So main orientations that you guys should be familiar with is 3 o'clock and 12 o'clock. Okay? The last stopcock is the one at the bottom, and this is going to drain all of your CSF from your burette into your collection bag. We have replacements upstairs. I really hope they're not with you long enough to fill this thing up. But that's how you would empty it into here every hour. Okay, just open and close. That's it. So that's the anatomy of your Codman. The Integra is literally the same, which is really nice. It just looks a little bit different. It's just simply snaps onto the pole. And it's got these little plastic things that you can hook on to keep it sturdy and tight on the pole, but it just simply snaps on the pole. Has the same string as well. And then it's got this here is how you would change the pop off. You just kind of pinch this on the side, which we'll play with. And then the collection bag is the same, and the transducer is the same. All the stopcock orientation is the same. The one thing to remember, the difference between the Integra and the Codman is the Integra leveling device comes with this really high-tech string. So you literally just pull this over to the patient's tragus, which we'll get to in a second, and level it this way. Whereas the Codman has this nice laser level. So you can literally just point it at the patient's tragus. So we'll play with that too. We have the laser levels ad hoc, separate upstairs. So you can always, get one and use that if you don't like the string.
And it's the old eye of the tiger technique.
Yeah, exactly. He said it, not me. Okay, so transducer setup. So here at Bayview, we use these transducers for our device. Like I said, the nurse upstairs will be setting this up for you, but this is what you'll see on the EVD. So it is a flushable transducer. You can use this on an A-line. You can use it on anything really, but we do not flush anything through here. It's just simply the one we use. Flushable capability, but we do not use it to flush. So it just attaches simply to the side of the EVD, and you're going to be leveling your transducer to what point? I just said it. Yeah. Zeroing point of reference is going to be your tragus, your external auditory meatus. So you're going to make sure that your transducer, laser level, fancy string level are all lined up at the tragus. So that's what I said there. We have both. Okay, so neurosurgeon determines the EVD is required. We come and help you set it up. 2-person assembly, like I said. Here's the antibiotics. So pre-procedure, 2 grams of Ansef always, unless the patient has a penicillin allergy, then we give them 600 of Clinda. There is an order set. It automatically comes and pops into your MAR. CT scan happens to confirm placement afterwards. Most of the time, they're going to make sure that this is still clamped. Go to CAT scan, confirm placement, and then when you get back, you can open it up, level it, and do all those things. The neurosurgeon will place the order sets. So like I said, we'll have our pop-off. There usually will be an ICP goal, notification parameters, and then when you get back to your bay, you're going to set the appropriate level, level it, and then zero it and open it to drain. Any questions about this? Good? Okay. So when do we clamp? So anytime that we are causing an increase pressure in the brain, we want to make sure that we're clamping so that we don't overdrain or start dumping CSF or blood or whatever is in the ventricle. Or brain matter, it happens, yeah. So we want to make sure we're clamping before we suction, before we transport, go to CAT scan and things like that. If the patient can tolerate it, which they should be if they're going to leave, they need to have it clamped. If we change the position or the head of the bed, if we re-level or zero, you need to just be able to get into the habit of always clamping that off before you touch the patient or manipulate the patient. Obviously, when we're getting a true ICP, we're clamping, because if we leave it open, it's not giving us a true ICP, right? So we need to clamp every hour to get that accurate ICP. If the patient codes, it's the last thing on everyone's mind, but you should technically clamp if you are starting chest compressions. Obviously, the increase in thoracic pressure is going to cause that patient to start dumping. So these are all, times when you should be clamping. So stopcock positions. So let's just review. I said them really quick, but let's just go through it. So I'll show you here and on the screen. So we're only manipulating the stopcock at the system level, right? We're not touching the one up near the head. So right here on the left, the burette's at the top. So we're like this. And the patient's at the bottom. So what are we doing here on picture number 1? What's happening? Are we draining? Are we clamped? Or what are we doing? Yep. Open to drain, off to transducer. Yes. Oh, sorry. What about number 2? What are we doing in number 2? Drain is off. So what are we going to see on our monitor? Which will give us, yeah, woo! All right, and then number 3, draining. What are we going to see on the monitor? Yep, little waveform, which is where we should be. If we're leaving the patient, we're doing other things, we're leaving them open to drain.
Is there any value to that number when the stopcock's in that position?
Anecdotally.
And trending.
Trending.
Yeah.
Yes.
So like if you see like fluctuations,
If it was reading 5, open the drain, and all of a sudden now it's 20. Yeah.
Go clamp.
Yeah.
Go clamp and get a real ICP at that point. Yeah.
It's also possible that there's some kind of clot or something like in there that's messing up with.
So you're just looking for like big drains, otherwise it's not inherently valuable.
Like you shouldn't be using that in your charting. Should not be something you document, but it's good for you to know. Yeah. Or conversely, if the waveform goes flat and then you walk in and your patient's like holding this. Yeah. One time I had a patient bite this and start drinking his own CSF because he had such bad, what is it, cerebral salt wasting or DI. Yeah, I'm not even lying about that. I wish I was. Okay, so these are what your wave. On that note, no, he didn't. If you ever find out though, Evan, let me know. Okay, so waveform. So this is what your waveform should look like when you clamp. It's this nice 3-stroke kind of sequential mountain-looking waveform. P1 represents arterial pulsation. P2 represents intracranial compliance. P3 is your venous pulsation. Normal physiology, it should like this nice kind of sequential mountain-looking waveform. Conversely, in B, if we see P2 greater than P1 or P3, then we know that there is poor cerebral compliance, but you will be able to see that in your exam and your ICP. So don't get too hung up, but just know what the waveform should look like. It should look like that nice kind of mountainous 1, 2, 3. So your epic orders, this is what you're going to get.
Can I just say one thing?
Yeah.
I don't know how often you'll see this, but where you will definitely see a change in this is if they have a craniectomy and there's no bone, you're not going to get really good waveform because there's so much compliance that there's really not much. It's just kind of what's going on now in that case. So I guess it's possible you'll have somebody maybe come in and they haven't gotten their bone back or something like that, but you won't see that with those patients.
Good point. The other thing you can do is auto scale like you would an A-line to kind of be able to see that a little bit better. So that's one thing you should be doing when you're troubleshooting. Epic order set. So you'll get recorded output of CSF. It'll be able to tell you if they can be clamped or not during transport, which 99% of the time they should be. The ventriculostomy management, which will give you your pop-off, the device type, the parameters, the measurement, which is always going to be millimeters of mercury. If there is a drainage goal, I will say 9 times out of 10, these patients are going to be open to drain, and then you're clamping every hour and recording that output. Very rarely are they putting these in necessarily, and you're just going to drain a certain amount every hour. But in your populations, you should mostly just see continuous drainage and then measuring every hour. Vital signs, obviously routine, going to be every hour. ICP monitoring, and then your antibiotics. And then this is going to be your notification parameters. So they'll say if they drain less than 5 cc's an hour, let neurosurgery know. If they drain greater than 30 cc's in an hour, let neurosurgery know. So they should give you very strict parameters on what to tell them is going on. Now these patients hopefully aren't going to be down there with you long enough for you to really see a trend necessarily. So this is going to be very important. For example, when they're upstairs and they've been draining 5 cc's an hour for 6 hours, and then all of a sudden they dump 30, that's an issue, right? But they're not going to be with you that long, hopefully. So just pay attention to this and see what neurosurgery wants you to tell them about if they were to go over or under.
Color too, like how bloody it is, that's going to be something you want to watch out for too.
Color and consistency, yeah. So in your documentation, your vital signs complex, you're going to pull down the ICP pressure row, and that's going to be every hour and with any changes. So if you go ahead and document your ICP is 15, and you already file your vital signs, MAP is 80, CPP is 65, it will automatically calculate for you. It'll show you on your monitor as well. And then you're just going to document what your pop-off setting is. It shouldn't really change too much, right, unless they tell you to. So, we set this to 15. We tell Epic it's 15. And then we're keeping it unclamped every hour. We're keeping it unclamped unless we're getting an ICP. We're going to add our LDA. So this is going to be your ventriculostomy LDA. Don't get too hung up on the location or orientation. Just make sure you put it in at least, and then we'll handle the rest upstairs. And then on your flow sheet, this is going to be, you're going to document on the actual LDA every 4 hours and with any changes. Clean, dry, and intact dressing. Draining, monitoring what the actual appearance looks like. So is it blood tinge? Is it pink tinge? Is it clear, cloudy, that kind of thing. And then the device assessment. So we want to make sure that all the connections are secure, that the system remains closed and intact, that it's patent, that we're leveling it. Positive cough spike just means that, things are functioning as they should. If the patient coughs, that we see, an increase in ICP on the monitor. Waveform is appropriate and that it's zeroed. So we're going to go through some troubleshooting scenarios. Any questions so far? No. Okay. All right, so your patient has been draining 8 to 12 cc's of blood, tinge CSF from their EVD for the last 3 hours. You come in and note that there is zero output in the chamber. What are you thinking, and what are your next steps? So you've had some output. You've been trucking along. Everything's been fine, but all of a sudden you go in and there's nothing in the chamber.
ICP too.
Check the ICP. Check the ICP. Yep. Check the device. What are we looking for on the device specifically?
Pink and tubing.
Yep.
I mean, like a visible clot if there was one.
Change in pressure.
Mhm.
Somebody forgot to unclamp it.
It happens. Don't touch my stuff. Yeah, all good things. So we're going to clamp and assess our ICP first and foremost. Notify neurosurgery if applicable, if something is totally weird and has not, things are out of the norm. Assess your clamp. So what I like to do is just run down, just like you would your vent tubing. If something is disconnected, run down from the head. So you're going to check that clamp at the head. You're going to check this little slide clamp, and you're just going to go down and make sure nothing is kinked and everything is open and patent. Especially like if someone transports for you, they might, their practice might be to clamp off at the head. I know Lifeline did that sometimes downtown. So just, again, be mindful and just run down the system. Assess the integrity of your dressing. It can actually kink up at the site of the dressing as well. Catheter and drain, and assess patency. So have you guys ever checked the patency of your device? Do you know how to make sure it's still patent? So what you would do is briefly, the key word here is briefly, you would take it and you would drop it to the floor, drop it below the level of the patient. And what you're going to look for is titling in the tubing. If you see titling, you know it's patent. If you see it starting to drip into the chamber, drip, 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 you know it's patent. You can bring it back up and level it and zero it again. But if you drop it down to the floor, you'll be able to create enough pressure gradient so that you can actually see titling in the tubing or dripping. If you're not seeing that, let neurosurgery know. They might need to troubleshoot it, flush it, things like that. Okay.
In reality, with these devices, I feel like I'm still probably just calling the neurocharge nurse and be like, hey, I got no drainage.
Yeah, and that's fine, right? Like, we're here to resource you. We're here to help you. I will say, if you guys get one of these at 4 o'clock in the morning, I have an 8-month-old. I don't sleep. So please call me. Like, I'm on secure chat constantly. And Sean is probably the same. Like, I don't care if you call me. And obviously we have people in-house that can help you too. But please feel free, like, anytime. It's totally fine.
Yeah, no, that's a good point. Like,
If it's zero out, but I'm not gonna try to fix that.
Mm-hmm. Well, go through your steps. Yeah.
For you to have the knowledge of that, what you can do, but your resource will always be there.
And honestly, even if you had zero output and you did see that your drain is patent, I'm still letting them know. Right? So.
By the way, this
We're gonna
happens.
document it.
Yeah.
You're like, why did you chart that?
Exactly. What were we going to say, Evan? Okay. Makes sense? All right. Last one. So you perform an assessment at 9 o'clock. Your ICP is 12 and your EVD is drained, 10 cc's of pink tinge CSF. You get away because Evan's patient next door coded and you need to go help him. So when you come back at 10 o'clock, you notice the head of bed is manipulated, the patient's flat, and there's 50 cc's of CSF in the chamber. So what are you going to do?
Clamp it.
Neurosurgery. Let them know.
Phone a friend.
Find an adult.
What are you worried about? We kind of talked about this earlier.
Dumping of CSF. So clamp it and raise the head of the bed up to 30 degrees, zero.
Get it releveled.
Pressure, and
You guys seeing a trend here?
notify neurosurgery and
Yeah.
whoever. Yeah, an adult. I'm gonna call an adult.
Come on, phone a friend. So we know our patient's clearly overdrained. Immediately relevel in zero. Check your ICP. Get a neuro assessment, okay? Because they're going to ask you, has anything changed? Their pupil's blown. We're in trouble, right? So get your neuro assessment. Notify neurosurgery. You're probably going to need a stat head CT because we need to see what their ventricles look like. Lock the bed controls. I know you guys have stretchers, so this isn't necessarily applicable, but if for some reason they're on a bed, you can lock the bed controls out. Sometimes putting a sign up is helpful. I know that there's a ton of people coming in and out of your bays, and it's very chaotic sometimes, so sometimes putting a sign up can just notify other people in other disciplines not to touch it. So what is our biggest risk with overdraining? I'm looking for a specific diagnosis. specifically. So we're causing pulling, right? That vacuum, that pulling. Not quite. Subdurals. So we're pulling on the meninges, right? And we can actually cause bleeding in a subdural hematoma. Yep. Bad. Sad. Bad, sad, subdural.
If you had a lumbar drain and you overdrain, then you'd be at risk for radiation because you're pulling downward on the drain.
And so it's pulling up, so
Yeah.
an injury locally at that space.
Yep. Subdural.
And then you get
So there's your little sign. Don't touch my stuff. There you go. All right, last one. So you're attempting to level 0 and transduce. Your waveform looks like this. What are your thoughts? What are your concerns? What are you going to do?
we don't know what a regular one looks like.
So this
Mountains, right?
Yeah, remember the mountain.
remember the mountain. Is this an adequate waveform if your patient is clamped and transducing an ICP?
No.
No.
You're supposed to have the 3 of them.
Yep. Those little mountains, right?
Uh-huh.
1, 2, 3. So what are you going to do? What are your thoughts?
Clamp to see if it changes.
So you are clamped.
Oh,
You're
I
clamped and
see.
transducing, and you get this.
Optimize it, make sure that it's actually like, it's not just too small to see the.
Auto scale it. Yeah.
Yeah.
Yep.
Gonna find an adult.
You're the
Evan's got
adult now.
neurosurgery on speed dial.
That's right.
Okay, so we know that it's not adequate, right? You guys said that. Check your stopcocks. Make sure nothing is kinked. Start at the head, like I said, and move down. Double check and make sure that it's actually open to the patient and the transducer and not the other way. We're closed. It should be flat in that case, but you never know. Check for catheter patency and kinks. Look at your ICP. Sometimes, like Sean said, in this case specifically, if there's severe brain edema, your waveform's not going to look very, very good. Neuro assessment, notify neurosurgery, and they may need to flush the system. Like I said, we don't flush the system. So it could be clogged with brain matter or blood or something like that. So like we all had said, contact the NCCU charge with any questions. Neurosurgery, you get them via chorus pager. They don't sign into secure chat. We obviously always want to expedite these people out either to JHH or upstairs. We talked about the CSF cultures, and Sean and I are currently working on a policy. We don't have one here at Bayview, so we're about like 75% done. So there
She
will be
says
a
we,
policy.
but it's really her.
Teamwork. Any questions? We'll start playing with them. I want to see you guys like pretend a level 0 open. We'll go through the stopcocks. Just get your hands on it.
In the ER, it's always because of hemorrhage that we're doing this.
So you might see it in your subarachnoid patients that come either with hypertensive bleeds or aneurysms, intracranial hemorrhage, intraventricular hemorrhage, trauma.
So usually, always something I'm bleeding.
Some kind of bleeding, or if the patient, came in with shunt failure, that's also a possibility. Hydrocephalus, anoxic injury, potentially, if they want to do this instead of a Codman,
And some of the bleeding is probably going to be the key for you guys because
Right.
other things they can wait. If it's edema, swelling, or even in trauma, swelling just like you get hit in the arm. Swelling doesn't happen instantly usually. It takes some time. So probably the bleeding is where they'll have to do it right there in the ED.
I was just wondering if we could get signs made, like, to put on the door and then above the patient, because we usually have so many consulting services and stuff. July's coming, just so that we can kind of all be on the same page, just so we don't have to also be like, if we get pulled somewhere, nothing happens.
Yeah, and I think that's a great point. I mean, that'd be a good idea to do that because all like you said, everybody coming in and out, and even respiratory and stuff. I don't know how. I think they usually assign to certain areas, so people that are assigned in the ED may not be real familiar with this.
Right. And we're not used to seeing it that much either.
Yeah.
Ideally, we're
Sometimes
not
we
gonna
don't
see
even
it
know
that
what's
much,
happening.
So
yeah.
if you're not used to it, you're not
Surprise.
thinking about it.
Yeah.
So
I think it's a good idea.
What I want to do for Patrina, and I told her this, I'll put this PowerPoint and the policy eventually, and we can even put the signs in a binder. So it'll be like a just-in-time
That'd be
binder for you guys
to
to
have
use
in
at
the
night
office.
or whatever.
because ideally the charge nurse would know that it's happening and can come up and put the signs.
Yeah.
If I could just say one other thing with this, definitely the NCCU charge nurse. There's sometimes, the other groups talked about the communication with neurosurgery is not always the most ideal, and surgeons are not always the most communicative. So there have been times, some of these cases, where the charge nurse didn't really know what was going on. They knew there was something going on in the ED, but they didn't, or there's a couple times they were making a bed for the patient, and then meanwhile
That happens a
neurosurgery is
lot.
transferring downtown.
Yeah.
Yeah.
So
Yeah.
so anytime you want to escalate up to the church, just let them know what's going on. Like, hey, this is getting a little wacky down here. Like, can you help? What's going on? And also, like she said, escalate it up to me or whatever. Have them call me if there's something real weird. For these transfers downtown, I think there's some cases, depending on what our bed availability, it may be worthwhile to transfer them up to the NCCU and then transfer them directly. So sometimes that doesn't always work because if you're moving people around, it's just
PCC won't want to give that bed up.
Yeah.
What's that?
The PCC won't want to give that bed up.
Yeah, so that's why I escalated up, right?
Uh-huh.
So if they're giving you a hard time,
So we can
Let
just
me
add
know.
you to the epic chat.
absolutely.
They're
Only thing I
gonna be
will
on my
say,
favorite.
so if it's 4 a.m., I'm happy to answer the phone call, but you need to call me because my phone goes on silent after 11 and doesn't come off silent. So phone calls come through, but everything else is silenced.
A
So
lot of times with neuro, it's been the case where they come down, they get everything ready. The nurse doesn't even know what's going on
Yep.
because we have such new people, and it's like we're just kind of oblivious that what's even happening. So then that upsets everybody and gets us all wound up because we're like, we don't even know what we're doing.
Yeah.
You know.
Would you be able to
There's a lot of other
add-
factors to consider than just.
Yeah.
Yeah.
Yeah. And they also need to know that, like, this is not your run-of-the-mill patient you guys
Yeah,
see every day. Like, they sometimes take that for granted upstairs because we do it all the time. But, like, we are going to help with that communication to say, hey, listen, like, they might need a little bit of extra help. Like, you have to be that resource
Yeah,
for them.
especially if we have a resource, like if Guy's here, we don't have to worry about anything.
Mhm.
Like he's strictly in that room. But the days that we don't, especially with like staffing issues, then that kind of puts us in a pickle because we're like,
Yeah, and it's always at night and change of shifts. Like,
Yeah,
literally.
yeah.
Yeah.
The change of shift thing.
Something like a low-hanging fruit would be add the signage that you were talking about as an appendix in that policy.
Oh, good idea. We
Oh,
can do
yeah,
that.
because then we can print it if we
Like,
can't
I
find
bet,
it.
We
like,
can absolutely do
Yeah.
that.
I bet you're looking at like we see these patients infrequently enough that you should be reading that if you have this patient, and so it would just be right there. You can click on and print it.
Perfect. And I will say I did adopt JHH's policy, and they have an entire appendix on how to set it up, how to level it, transduce it, zero it. It even has the entire manual for like the Codman in it. So like,
this makes it a lot less scary.
Yes.
Like actually knowing what's what and what we're responsible for. Because before we just saw this thing and we're like, we know something's going to somebody's head.
Yeah.
Yeah.
It was scary.
It's touching their brain.
Yeah.
Don't
Yeah.
ruin it.
Yeah, it is.
Yeah.
This is
It's very
definitely in that,
intimidating.
this is definitely in that category of this is super scary until I start to learn about it, and then it's like, oh, it's not so bad.
Yeah, that's
Yeah.
a super primitive device.
Yeah,
it is, right? Like,
It is.
It's pressure. It's not. Yeah,
It
it's
is a
just,
gravity-based.
Yep.
I could make that.
Yep.
Minus
Absolutely.
the transducer.
Yeah.
if Evan makes you an EVD, probably don't use it.
Yeah.
But it's fine if you want to.
That's gonna be added to the
But
policy.
mad props, though.
All right, let's play with it. And any other questions, concerns?
Is that a 9 or a
you guys have?
4?